Assalamualaikum warahmatullahi wabarakatuh. Saya Khairul, mewakili Jabatan Kecemasan HKL mengucapkan terima kasih kepada Dr Khairil Erwan Khalid, our ID Physician HKL, kerana sudi memberikan topik segmen kita pada pagi ini. Jadi tanpa melengahkan masa, saya menjemput Dr Khairil Erwan untuk memberikan segmen pada pagi ini dengan topik COVID Management and Overview. Silakan.
Okay, Assalamualaikum and a very good morning. Terima kasih Dr. Khairil for the introduction. First of all, I would like to thank the emergency department for giving me the opportunity to sort of share with all of you what basically an overview of COVID-19 management and a little bit on the latest guideline which was published, which was released last week yeah. Okay, I think all of you are very familiar with this clinical categories or clinical staging of COVID-19. So it can be broadly classified into mild category and severe. So kalau Cat 1 to 3 itu considered as mild, whereas Cat 4 to 5 is considered as severe. Again, if you listen to COVID talks, I think most of the time they will show you this picture of natural history of COVID-19. Like as we know, the early part of the infection, usually within the first week of illness, it is predominantly viremic phase ataupun kita panggil viral response phase. So the early infection. So patients who come in this early part of the illness, they will exhibit predominantly viral-like kind of features, like fever, myalgia, arthralgia, non-specific sort of undifferentiated kind of symptoms. And generally, these patients would be classified in the early stage Cat 1 and Cat 2. And then as time goes by, usually beyond day 5 to day 7 of illness, they will enter the pulmonary phase. This is when the pneumonia comes in. And then it can be further classified into whether it's just a, simple pneumonia ataupun pneumonia that actually make the patient hypoxic and requiring oxygen supplement. And then this would progress to Cat 3 and Cat 4. And then generally within the second week of illness, generally more than day 7 of illness onwards, and then they will enter the host inflammatory response phase. Ataupun this is when I think all of you are familiar with the term CRS, cytokine release syndrome, so that comes in. So I think it's something like what we practice for dengue as well. Knowing the natural history of the disease, it helps you to determine what would be the appropriate treatment to be given for the patient accordingly. Again, this is just to show you the early part of the illness, generally because pulmonary phase belum set in lagi, so generally oxygen saturation would still be maintained. As I've mentioned, the early part is mainly the viremic phase, so the viral load would be high within the early onset of the disease, and then the inflammatory response masih rendah. But as time goes by, you can see that when it enters a pulmonary phase, the oxygen saturation comes down, and then the viremia will come down, and then your immune response or the inflammatory response will come up. So at this particular sort of juncture of the time course of the illness would be beneficial for the practicing, doctor who's attending to the patient, whether to decide what sort of treatment is appropriate for this particular patient. We know that there are certain group of people who are actually more at risk to get severe disease. Either they come in severe disease stage to you upfront to the emergency, or they come in with early part of the illness, Cat 1, Cat 2, and then they progressively deteriorate. So who are these people? We know that the older you are, the highly likely you to get severe disease, and then all this pre-existing comorbid, especially CKD and hypertension, And more so now we see that amongst our younger group of population with obesity would actually progress to severe disease more. And then all the other risk factors that leads to some sort of immunosuppression that predispose someone to have severe disease. So bila jadi severe disease ni, generally there's no specific day of illness, but it ranges within day 5 to day 10. But sometimes it can actually progress much earlier, so we don't know. But this is just an average range of when they deteriorate and when do you actually look out for signs. When do they deteriorate? So what are the warning signs? Sort of how to predict them, they might deteriorate to severe disease. So here it has been classified into 3 categories in the clinical perspective, laboratory and radiological. So kalau clinical perspective, generally if somebody who comes in with persistent fever ataupun dia tak ada fever and then suddenly there's a new onset of fever during that time, it's a warning sign. And then you need to look out for symptoms, mainly lethargic, anorexia ataupun cough. And then clinical examination, you need to look out for exertional dyspnea, count the respiratory rate, so any RR more than 25, and saturation on room air less than 95%. So these are warning signs. If you look at the lab parameters, if you do a CRP, one reading, a single reading of more than 50 is considered as a warning sign. Ataupun if you have a serial CRP, you see that the CRP is climbing up, so that's a warning sign. Ataupun absolute lymphocyte count less than 1 ataupun dropping in trend. And then radiologically, if you look at the chest radiograph, you nampak more than a single lobe involvement, so multilobular involvement. Ataupun if you have a serial chest x-ray, you see a very rapid worsening chest x-ray. All right, so okay, so I'm just going to brief through what are the management principles from category 1 to 3, which is a mild illness, and then we go look into Cat 4 and Cat 5. So in Cat 1 to 3, what we need to do is actually we need to stratify the risk, and then we need to detect the warning signs or symptoms. And then the main thing is actually to detect early hypoxia so that we can intervene. Right, as I mentioned tadi, this is data from our own Malaysian cohort. We know that the higher the age group, the more comorbidity you have, the higher percentage or risk of you to deteriorate, whether they come in Cat 4 and above, or they deteriorate from the early category to Cat 4 to Cat 5. Again, mild disease or the early part, the viremic phase, Cat 1 to 3, usually it happens within the first week of illness. And then subsequently, when you enter the second week of illness, so there is this intersection where between viremic phase to host inflammatory phase, there will be warning signs. So look out for warning signs when they enter day 5 onwards. All right, this one just gambar lah so that we can actually remember and look out for the warning signs. Yep. All right. So as I mentioned tadi, people with warning signs or with warning symptoms, we need to look for hypoxia. That's the main aim, is to look for hypoxia. So this one tadi I dah mention, look out for all these signs and symptoms. And then how do we pick up hypoxia early? We need to ask whether the patient has exertional dyspnea, and then objectively we should be counting the respiratory rate for 1 minute to see whether the RR is more than 25. And then we do this 1 minute sit and stand test. Yeah? Ataupun some people mention it as ET, exertional test. All right, so you need to sort of, so this is what we adapted from Hospital Sungai Buloh, who should have the exertion test. So not everyone with COVID-19 needs to do the test. So generally only category 1 to 3. Kalau somebody dah masuk cat 4, that means they already have evidence of hypoxia. So there's no need to do an ET. So more so if somebody in cat 3, you should actually look out for exertional dyspnea ataupun to do an exertional dyspnea test every review when you see the patient. Okay. So this is something that we can empower our nurses and MAs to do it when reviewing the patient, and it should be incorporated as one of the vital signs monitoring for COVID patients. All right. So picking up hypoxia early, so I'm sure again you've heard of this term silent hypoxia, happy hypoxia. So we need to look this for, and also to watch out for patient who is compensating by increased respiratory effort, but they're not really dyspneic. So there's something that we need to look out for. Now let's move on to specific sort of pharmacological treatment for COVID-19. So it can be broadly categorized into antiviral. And then we have our steroids or other immunomodulatory agents, mainly tocilizumab and baricitinib. And then we have another part called anticoagulation. But before that, this is what we generally do in the ward. I'm not sure whether it's feasible to do in the emergency department because of the space, but before all the pharmacological treatment and everything, we always teach our staff or our doctors to actually make the patient into prone position. We can actually empower the patient to do themselves, because we know that by doing this prone position, it also helps to improve the respiratory function. So let's talk about antiviral. So generally, antiviral that we commonly use at the moment is actually favipiravir. Those days, not really. Last year during the first few waves, we used to guna antiretrovirals, Calitra, but we know nowadays that there is no evidence of efficacy on that, so we move on to favipiravir. But again, in regards to favipiravir, the efficacy is still not proven. If it's proven, it's most likely effective in the early part of the illness, in the viremic phase. So when do we use it? So generally in high risk group. So somebody who comes in category 3 with a high risk. So not all cat 3 gets it. So those cat 3 with, let's say, age more than 50, who has got more than one comorbid, or who's got underlying end-stage renal failure or immunosuppressed, then you can consider giving favipiravir, provided they come in within the first 7 days of illness. And then generally, category 4 onwards, we do give favipiravir. But now there is a question whether there's a role of favipiravir in patients in cat 4. With the latest guidelines that was released last week, if you have seen it, actually favipiravir dah tak ada dalam guideline kita. So they have talked about different sort of antivirals. In particular, they've mentioned about remdesivir. Okay, so favipiravir, so generally these are the common side effects, but generally they are safe. We do see some patients on favipiravir with increased ALT, but we usually monitor. So these are some of the important drug interactions, and it is contraindicated in women of childbearing potential, or obviously if they are pregnant, they can't use, and then and creatinine clearance less than 30, we should avoid. So it's actually not licensed as COVID treatment. So it's actually off-label use. So generally, if you want to start favipiravir, you need to get consent from the patient. Okay. And again, there are, if you look out there are a lot of these controversial things about ivermectin. As of now, we know that the WHO and the CDC, IDSA, they do not recommend using ivermectin. outside of context in the clinical trial. So in fact, I don't see any guidelines out there that actually list ivermectin as part of their treatment guideline. It's just meant for clinical trial because again, there is no, there are insufficient data to sort of recommend for or against the use of ivermectin. If some of you are aware, in our country, we do have this ivermectin study. It's called the ITEC study. So Kuala Lumpur is one of the sites. So it's basically a multi-center open label randomized controlled trial. So we recruit patients who are in Cat 2 and Cat 3 only with the age of more than 50 and have one comorbidity, and they come within the first 7 days of illness, because the primary outcome is actually to see whether these patients would actually progress to Cat 4 and Cat 5. It is supposed to be completed by end of September. As of now, for this ITEC study, they have reached almost 30% of the study target that they want to look at, and they have actually have a prelim analysis about 30% of the subjects. They look at the safety first. At the moment, there is no concerning safety issues by using ivermectin. So they actually ask us to continue recruiting more patients. I think when they have reached almost 50% of it, they will come up with prelim analysis in terms of efficacy. But at the moment, tak keluar lagi. They just came up with the safety prelim punya analysis. So at the moment, we are still recruiting patients. But I think for the past couple of weeks, we didn't really have much opportunity to use because they want Cat 2 and Cat 3. So as you know, majority of our patients who end up with us here are Cat 4 and above. So the recruitment was a bit slow lah, but it should pick up soon. And we've actually gotten my apes to be included in the site. So hopefully with that, we can actually speed up the recruitment process. Okay, moving on to steroids and other immunomodulatory agents. Again, I think the mainstay of treatment for COVID is generally by using steroids. But again, to use steroids in COVID, it has to be used at the right time, and always that we keep on mentioning, saying that when you want to start steroids for someone with COVID, do not start too early, okay? So when is it too early? So when somebody with COVID who is not hypoxic, or generally if they are in the first week of illness, because I've shown you just now, the first week of illness is predominantly the viremic phase. So antivirals would be more beneficial as opposed to steroids. And then somebody with low CRP, less than 50, ataupun if you calculate the neutrophil lymphocyte ratio, it's low. So these are some of the features to actually make you think, is it too early for me to start steroids ke tak? Yeah? So you should, by right, should not start steroids when they are having all these features. If you have seen, I'm sure you've seen this recovery study looking at using dexamethasone at a dose of 6 milligrams daily for 10 days. We know that there is a role of using steroid, particularly dexamethasone, when already hypoxic. Yeah? So if you look at here, those who use oxygen only or invasive mechanical ventilation, they tend to do better with dexamethasone as opposed to if they're not hypoxic. Talking about steroids, I think there are many, tak ada like a proper sort of consensus what type of steroid is beneficial, at what dose is beneficial. So it's something you need to look at, the balance of it lah, to use it. So what guidelines do we have so far? I'm sure you've seen this Malaysian Society of Intensive Care consensus statement by actually suggesting using dexamethasone. It did not mention about methotrexate. So depending on what oxygen they require, kalau nasal prong or face mask up to 8 liters, so it's adequate to use dexamethasone 6 milligrams daily. This one as following the recovery trial punya study. And then if somebody who needs higher oxygen requirement, high flow nasal cannula, NIV or ventilation, so they use this dose of dexamethasone 20 daily for 5 days and then 10 daily for 5 days. So this is actually based on the Codex trial. So when and how to initiate steroids? So what we can sort of summarize and we agree upon is that all category 4, because category 4 you already need oxygen supplement, so those in category 4 on oxygen will need steroids. Okay, but in category 3 with positive exertion test, it should also be classified as Cat 4, thus steroids is warranted. Okay, so Cat 3 with positive ET ataupun category 4 onwards, they need steroids. Okay, and Cat 4 ni, it can be further divided. If you see our latest guideline pun, they dah further divided ada 4A, 4B, 5A, 5B. So kalau category 4A, 4A means that somebody who needs nasal prong at least up to face mask 5 to 8 liters per minute. So these are 4A. It is generally recommended to use IV dexamethasone 8 mg daily on nasal prong atau face mask if they are not obese. If they are obese, so obesity means BMI more than 30, it is suggested to use Dexa 12 milligrams daily. Some people might ask, kenapa Dexa 8, recovery trial guna 6? Generally, I also baru found out from our pharmacy that dexamethasone 8 actually contains the base of the Dexa of 6 milligrams. So in fact, if you kasih 8 milligram, you're actually giving 6 milligram to the patient. So that's why they come up with the figure 8. All right, so this is generally what is recommended for category 4A. Somebody who comes in category 4B, maknanya requiring more than face mask. So venti mask up to non-invasive or even ventilation, they actually suggest to use upfront methylprednisolone, and the dose here again they cap it at 2 milligram per kilogram at least 3 to 5 days, and then you see the response. Dia tak ada macam blanket rule you have to use straight 3 days ke tak. So it's 3 to 5 days minimum pun kita kasih 3 hari lah. Jarang we give beyond that, and then you need to see the response. Atau alternatively, you can use IV dexamethasone 20 milligrams daily. So that's the dose equivalent. And then for Cat 4, you need to monitor the CRP every day to see the response, because the main thing of starting steroid is actually to halt the progression of the CRS. So one of the good parameter that we look into is actually CRP. Also, you can look at the ferritin, but somehow CRP comes back earlier than ferritin, and I think ferritin is more of a surrogate. So I think we generally use CRP in the wards. But if the CRP maintains or is actually increasing, patient is still hypoxic and they are still not improving clinically, so you may want to consider increasing the dose of the methylpred or consider immunomodulatory agents such as dosi or baricitinib. So I'm going to talk about that later. Increasing the dose of the methylpred is something controversial. Generally in the ward, sometimes when we give 2 mg per kg, tak improve. There are some physicians who naikkan terus to either 250 milligrams or even 500 milligrams. Again, this is something tak ada consensus. If you look at the guideline kita pun, dia kata there's no recommendation against or for the use of that escalation of therapy. But it is something that you can consider. But again, now with the availability of Tosi and baricitinib, so maybe we try to, this is what we agree upon lah in the department, is that we try to cap it at 2 mg per kg, and then we use Tosi ataupun baricitinib rather than increasing the methylpred dose further. Okay, and then do CRP and ABG stat if the patient deteriorate, and then we can actually send serum interleukin 6 to the lab to sort of gauge whether the CRS is really actively ongoing ataupun tidak lah, because sometimes when you have high CRP, you cannot differentiate whether are we dealing with bacterial infection or is it CRS going on. So we do set the IL-6. So cut off IL-6 kita is actually 7. So anything more than 7, we do see sometimes IL-6 come back beratur-ratur. So we know that the CRS is still active. So that's when we go aggressive with the steroids and using the immunomodulatory agents as opposed to by using antibiotics. This is what we adapt from Hospital Sungai Buloh. And this protocol is something just as a guide, as I mentioned tadi. So somebody who comes in Cat 4A, we start the default treatment, as I mentioned tadi, Dexa 8 mg. Kalau BMI more than 30, 12 mg. If patient becomes more hypoxic with raised or persistent high CRP, and then they actually suggest to escalate to metapred at 2 mg per kg or Dexa 20. And then kalau tak ada improvement juga, is actually to carry on with metapred, but now you add on IV tocilizumab. Somebody who comes in upfront category 4B, you can actually straight away bang with metapred 2 mg per kg and then follow this algorithm lah. But once the patient has improved, please put them back on a default treatment of the Dexa 8 ataupun 12 depending on the BMI. Don't just carry on the current treatment, because this is only the initial treatment to actually bring down the CRS or I mean to halt the CRS from progressing further. All right. This question point is a little bit difficult to answer. How sort of to step down the steroid, because in the guideline is not clearly stated how to do it, but generally what we can sum up is that as I mentioned tadi, high dose steroids, metapred, the dose 2 mg per kg or above, again are not proven therapies. Based on what we look at patients who have COVID and they have the sequelae of organizing pneumonia, particularly the histological type of acute fibrinous organizing pneumonia, we know that steroids help. So it's basically done out of desperation. So that's why we recommend using steroids in COVID. We don't know by using high dose steroids do more harm than good in the long run. We don't have data on that. And it should be used as pulse therapy 3 to 5 days, beyond 3 days only in exceptional cases. But the key thing is that as soon as a patient improves, you need to step down your steroids, okay? And in conditions, sometimes we do see the patient persistently requiring oxygen, tak improve, clinically still tachypnic, tapi you tengok CRP dia actually has come down with the steroid. So sometimes we do step down the steroid to the default treatment of Dexa 8 or Dexa 12, even though patient is still requiring oxygen. As long as the CRP actually has come down, so we do step down the steroid. Okay, so how to taper off steroids? So generally we divide it into two lah, whether somebody without OP or somebody with OP. OP means organizing pneumonia. So those without organizing pneumonia, they have good response to the default treatment of Dexa 8 or Dexa 12, generally beyond day 10 of illness. And then you are able to wean off the oxygen. So once you are able to wean off the oxygen, while they are still within that treatment duration of the steroid, you can consider switching IV to oral Dexa. So oral Dexa here we use 6 milligrams. Sebab oral Dexa kalau 6 to 6 lah, bukan macam IV. Sebab IV tadi as I mentioned, kalau 8 milligram means they are getting 6 milligrams. So we switch to oral Dexa once we can off oxygen and they can tolerate orally well. And then you can maintain the dose, either IV 8 or oral 6 throughout the course. of the duration that needs the steroid. So dexamethasone duration dekat sini, this is again a general guideline. It's not set in stone. It's something that you can use as a guide. So kalau you are able to wean off the oxygen fast, that means they require oxygen less than 5 days, you can consider giving the DEXA up to 1 week cukup. So kasih 8 mg atau 6 mg tu 1 week and then stop. Okay. Tapi kalau you have difficulty to wean off the oxygen and requiring oxygen lebih daripada 5 hari, then you may want to consider giving the steroid up to 2 weeks and then stop. Okay. So these are patients who improve and they don't have clinical or radiological evidence of organizing pneumonia. This is a general guideline. How long do we give the DEXA for? But for those of apa ni yang ada organizing pneumonia, which nowadays we are seeing more patients with organizing pneumonia, generally we get our IPR team to be involved because they would give input on the steroid requirement, because the steroids are more prolonged in a tapering manner. So generally they will need metapred pulse 3 ke 5 hari, and then they will switch to oral prednisolone. The dose ranges 0.5 to 1 milligram per kilogram daily, depending on the severity of the OP on HRCT. And then they will taper down the prednisolone every 5 days by 5 milligram until they see the patient back dekat klinik diorang. So usually we will co-manage with IPR. And then we can aim to allow discharge once they improve. Sometimes if they are beyond day 14, they've been off tag and we have difficulty to wean down the oxygen, then we ask their help to take over and then do pulmonary rehab and so on. This is something that courtesy from Dr. Shakirin IPR. So how they talk about tapering down prednisolone for OP. So they classify the patients into 3 categories: mild, moderate, and severe. So if the patient is does not require oxygen, that means manage to wean off the oxygen, and then there's minimal to mild involvement of in the lungs, that means 0 to 50% on the HRCT, they are categorized as mild stage. Kalau requiring oxygen susah nak wean off, and then ada moderate involvement on HRCT, considered as moderate stage. And then those yang requiring ventilation, the highest oxygen requirement ventilation, or memang ada ARDS or Cat5 or severe OP on HRCT, they are termed as severe. So this is the general management of steroid therapy. Kalau dia in mild category, dexamethasone 10 hari dah cukup, because we are able to wean off the oxygen. So we treat as if they have no OP punya guideline tadi tu. And then moderate, usually they start off with 0.5 mg per kg per day, taper 5 mg every 5 days. Kalau severe, they might give up to 1 milligram per kilogram per day, maximum 60 milligrams daily, and then they taper down 5 milligram every 5 days. So usually kalau dah ada severe OP ni, IPR would give their input lah. They will help us to decide on the dose of the steroids and how to taper down and whatnot. All right. So for us in the wards, when do we actually consider to do HRCT ataupun CTPA? So if somebody who has got worsening opacity on the chest X-ray with or without increasing trend of CRP, provided there's no evidence of bacterial infection, you need to consider HRCT sebab nak rule out organizing pneumonia. If you have increasing oxygen requirement or you have difficulty to wean off the oxygen, generally beyond day 10 to day 14, we will get HRCT and CTPA to look for OP ataupun pulmonary embolism, because we have seen many patients who have subsegmental pulmonary embolism leading to this so-called chronic hypoxia and difficult to wean them down to room air. Those yang kita minta CTPA saja is that somebody who is still hypoxic, still breathless, Tapi bila kita buat repeat X-ray, nampak X-ray dia dah improve daripada the first X-ray. Tapi patient still breathless, still hypoxic, ataupun kalau kita exitkan dia, there is desaturation. So these are the patients that we need to think whether are we dealing with pulmonary embolism or not. Okay, right. Again, as I mentioned tadi, steroids can be harmful. Like we should not start steroids too early, and we should not start steroids too late as well. So there are these two sort of distinct phases lah. So tadi yang early part tu tadi is the viremic phase. So we've talked that about the role of antiviral, and then the inflammatory phase, the second wave of illness, that's when we think steroid ada role, and then after the complete inflammatory phase tu, they will go into recovery phase. So most of the time in clinical practice susah nak differentiate inflammatory phase, recovery phase semua ni. Sometimes the day of illness tu pun we have to take it with a pinch of salt, because you know we don't know whether betul ke calculation day of illness tu sometimes. So it's difficult, I know, in clinical practice, but generally, as if you know the patients have gone into recovery phase, if you start steroids, they would probably have more risk as opposed to benefit. So because we know in the recovery phase, steroids could be harmful because they might predispose you to get secondary infections. You know, we have seen patients with sepsis, especially line-related sepsis, and some of my colleagues dekat Sungai Buloh actually have seen COVID-associated aspergillosis, you know, because of usage of steroids. And then, of course, all the complications of steroids, lah, GI bleed, and so on. So need to be careful and to sort of weigh the balance on when to start or not to start steroids. So generally, this is again a guide. Inflammatory phase, usually within the second week of illness, usually they would have warning signs or symptoms before they go into that phase, and then all these parameters lah of CRS. And then recovery phase generally is already beyond second week of illness, third week of illness. They are actually improving, they feel less lethargic, less breathless, oxygen requirement reducing, and the CRP is generally coming down trend or low. But bear in mind that in recovery phase ni pun sometimes because they get complications like organizing pneumonia and also sometimes I agree it's difficult to sort of, you know, distinguish this both phases. But those yang clear cut that you know that they are in recovery phase, we need to make sure that these patients have, as I mentioned, how do we decide whether they are in recovery? Clinically, patient feels less breathless, they are not tachypneic at rest, they are able to ambulate to the toilet, the oxygen requirement is actually coming down, and the CRP is coming down. So we identify these patients in the ward so that it helps us to plan ahead to step down these patients, whether to send them to HKL or whether to send them to MAIPS, and then we start the discharge planning early. So in recovery patients, as I mentioned tadi, if they are still on this IV DEXA, so you need to consider switching to oral DEXA, and then stop doing daily bloods, and then start discharge planning, and then transfer to step down, and so on. Yeah. Okay, this one dah mentioned. Okay. A bit on tocilizumab and baricitinib. So these are the two immunomodulatory agents that are available in HKL. Tocilizumab is IL-6 inhibitor, whereas baricitinib is a JAK1, JAK2 inhibitor. So both are generally an anti-cytokine agents. Yeah. So tocilizumab, we follow what the NICE guidelines sort of recommends. Yeah? So here they strongly recommend to use toci in COVID patients if they have or having completed course of steroids, such as DEXA, or they cannot have steroids. So consider using toci in these patients. They have not had other interleukin-6 inhibitor, or there is no evidence of bacterial or viral infection. So generally, these are the recommendation on when to use toci. Or they either need supplemental oxygen, or they have a single CRP reading of more than 75, or they are within 48 hours of starting high flow nasal cannula, NIV ataupun ventilation. So generally macam you look here that how we use TOSI is basically you've already exhaust by using steroids, especially methotrexate and all, and patients still not improving, CRP is still high, then that's when you consider using tocilizumab. What about baricitinib? So baricitinib is something that we use here in HKL as well. So baricitinib probably would have role if we start much earlier. Okay, so when to consider baricitinib? Again, this is based on what the NIH recommends, and also we adjust and adapt a bit from what Sungai Buloh use as well. So somebody who is on high flow mass, that means category 4B onwards, with increasing CRP or high CRP and rapid clinical progression. We will also consider starting baricitinib as early as the patient on face mask, 5 liter and above, but those with rapid progression, yeah, or a very bad chest X-ray to begin with, a very high CRP, single reading we take as more than 75 also, ataupun CRP increasing, and they're not improving with dexamethasone. So you can consider baricitinib, okay? It is not recommended to initiate in intubated patients because baricitinib takes at least 48 hours for the onset to work. And then also because of the gut absorption, and also TOSI would actually be better in intubated patients than Bari, because Bari is actually oral tablets. Yeah? But the thing is that when you want to start baricitinib, it is beneficial to start in the early part of the disease. So we take the cutoff less than day 10 of illness. Antara day 10 to day 14, we see case-to-case basis. But generally, kalau beyond day 14, we don't consider giving baricitinib. Yeah? And then those who have not received TOSI can be given Bari. We don't give together. And then again, baricitinib should be avoided in end-stage renal failure because creatinine clearance less than 15 should be avoided. And then, so creatinine clearance more than 60, we can give Bari. Below that, you need to half the dose of the Bari. Because baricitinib, we give 4 milligrams tablet. Unfortunately, we only have 4 milligram. Kalau creatinine clearance less than 60, kena kasih 2 milligram. But masalahnya Bari ni tak boleh pecahkan, tak boleh crush or patah setengah because we don't have 2 mg. So that's why we don't use Bari in creatinine clearance less than 60. Or if somebody who's got blood clots, confirmed DVT-PE, baricitinib is also contraindicated. And then again, pregnancy. I guess there's not much data looking at baricitinib in pregnancy. But we have done out of desperation by using baricitinib in pregnant COVID patients. But again, this is something that it has to be weighing the risk versus benefit, and to have an MDT with our intensivist and our ops colleague, you know, and talk to the patient, and yeah. Right. And lastly, a bit on anticoagulation. We know that somebody with COVID, they are hypercoagulable. So sort of divided into 3 categories. So you have the full dose anticoagulation, you have the high prophylactic dose anticoagulation, and then you have the standard prophylaxis. So full dose anticoagulation in those who have confirmed PE ataupun DVT lah. So I'm sure you know the dose, 1 milligram per kilogram, 12 hourly. In confirmed VTE ataupun patients who you have very high suspicion of PE. So if somebody who has sudden unexplained deterioration in oxygen, that means suddenly oxygen requirement getting more, tapi you repeat chest X-ray, as I mentioned tadi, nampak improving. So you have to consider whether are we dealing with PE ataupun tidak, ataupun unexplained tachycardia, hemodynamic instability, or acute copamine, then you have to consider PE. You can start the full dose anticoagulation empirical first and then get your CTPA urgently done. And then this high prophylactic dose anticoagulation, we advise to use in category 5 onwards. So mainly patients in ICU, if they have no contraindication or the renal function is okay, we give 0.5 mg per kg 12 hourly. And then the standard dose prophylaxis lah, either 20 or 40 milligrams of Clexane daily depending on the renal function. Those who are in category 4, maknanya when somebody already on category 4, when you start the steroids, the DVT prophylaxis should also be started. And generally, how long do we give is that if you don't suspect VTE in these patients, or memang tak ada evidence of PE or DVT, once they are discharged, we will just stop the anticoagulation immediately. Ya, tak perlu nak continue further ataupun, you know, ni lah, once they are discharged, we will stop. Okay. Right. So this is apa ni, our latest guidelines yang released last week on the 9th of August. So if you have read this, you see that now patients in Cat 1 to 3, there is no specific treatment recommended. Mainly supportive and symptomatic therapy and monitor for warning signs, as I mentioned earlier. Here dia dah tulis steroid is not recommended in non-hypoxic cases unless for other indication. And then there is this medication called Regent-Cov. If you have it, unfortunately HKL tak ada. I don't think there's a plan to buy yet because it is very, very, very expensive. So if you do have this Regent-Cov, if the patient comes in within first week of illness and meet all these criteria, you can consider using it for Cat 1 to 3. Cat 4A, so Cat 4A is those yang perlukan nasal prong up to face mask 5 to 8 liter per minute. Here is recommended to use Dexa, as I mentioned tadi, 8 mg daily. Kalau BMI more than 30, you can give 12 milligrams daily, and then they write here 10 to 14 days or until discharge. And then step down to oral Dexa 6 if there is improvement or the patient in recovery phase. Alternatively, kalau kita ada remdesivir, you can actually combinekan Dexa 8 atau 12 ni tadi dengan remdesivir for 5 days, actually for 6 days. Remdesivir again kita tak ada lagi kat HKL, but we have actually sent off the purchasing. We asked for I think 8 patient quota first, tapi tak sampai lagi. So you know, there would be an alternative later, but this is something that we can consider using. So here kan dia dah mention tadi, I said for patient with progressive hypoxia, increasing high CRP, inflammation and all, dia kata consider methotrexate 2 mg per kg 3 to 5 days pulse, and then step down once patient improves to default treatment. All right. Here just to highlight, dia kata there is currently insufficient evidence to recommend for or against use of course of methotrexate as escalation of therapy. If the methotrexate 2 mg per kg does not work, then you may want to consider adding on immunomodulatory agents. All right. Category 4B and 5A, 4B is basically requiring ventimask and above. And then 5A is basically non-invasive ventilation, whether the patient is on NIV or high flow nasal cannula. It is recommended to use methotrexate 2 mg per kg upfront. And then once they improve, you step down to Dexa 8 to 12. Again, alternatively, if you have remdesivir, you can consider Dexa and remdesivir, ataupun steroids with tocilizumab, yeah, ataupun baricitinib if toci is not available. But generally, we don't use that as upfront. We use methotrexate 2 mg per kg first. Kalau tak ada improvement, baru kita consider adding on toci. This is just the dose and the recommendation duration for toci and bari lah. All right. And category 5B, those who are ventilated or with organ failure, again same thing. Macam category 4B dengan 5A, to use methotrexate 2 mg per kg, and then once they improve, we step down. All right. A bit on COVID in pregnancy. again, this is in the guideline. It says here that the therapeutic management for pregnant patients with COVID should be the same for non-pregnant patients. Yeah? So it shouldn't be different. Of course, if there is a need to do chest X-ray in pregnant patients, again, the same thing lah. Talk to the patient, get the obstetric colleagues involved, and then if it's needed, you have to do the X-ray, then you do. And then here they've put actually a table of suggested steroid to use depending on gestational punya pregnancy age. So generally here they put if within 24 to 34 weeks, the steroid is basically used for fetal lung maturity. So this is a suggested steroid. If less than 24 weeks or more than 34 weeks, you can use, prednisolone here or hydrocort here. But again, we do see pregnant patients who are really, really ill. So we don't generally use this. We use as in the non-pregnant adult guidelines lah. So we do use metapred for pregnant patients who are in category 4 and above in pregnant patients. But again, this is usually with discussion with the intensivist and also with our obstetric colleagues lah, in terms of the best treatment for these patients. Right. If you all have, I don't know, some of you probably have done or seen this. So there are links, that you can actually learn more about COVID on YouTube. And also there is this online training on COVID-19. So you can sign up for free if you have time to go through it. Right. That's it. Thank you. Any question?
Good morning, Dr. Khairil.
Hi, morning.
Hi, Jessica here, the emergency physician.
Yeah.
Hi, I just want to ask you a question. Yesterday in recess, okay, before that, thank you very much for your wonderful presentation. Okay, so yesterday in recess, we had a patient, he's day 16 of illness.
Right.
He was an Indonesian man. He did not come in at all for the past 16 days. He was at home. Then when he came in, he had a really bad chest X-ray. However, his FBC showed a bacterial picture. So the white count was 20 neutrophil predominance.
Right.
Yeah. CRP came back of more than 350. So we were just wondering in whether there will be a role for metal pred in this kind of patients because it's already day 16. SpO2 when he came in was about 80% under room air, so he was put on modified CPAP. Yeah, so we just wanted to know, and would this patient be classified as a clean patient or not?
Right. Okay. I assume so. The chest X-ray is very
bilateral haziness up to the upper zones.
Right. So generally beyond day 14 of illness, we look for two things lah. Mainly, we need to rule out organizing pneumonia. And secondly, whether this patient has got secondary bacterial pneumonia. Again, in this situation, we cannot be certain until we get a HRCT for this patient. But if this patient, obviously will end up in the ward, what we do is that we will cover with broad spectrum antibiotics. We would send off procalcitonin just to look whether it favors more of a bacterial infection or not. And then we will get an urgent HRCT. In terms of the steroids, it's quite iffy in the sense that whether should we give metapred, should we give Dexa or not, because for organizing pneumonia, the treatment is still steroids. So sometimes, if this patient would have landed in my ward, I would probably just start Dexa 20 milligrams first, and then cover with antibiotics, do procalcitonin and get HRCT, and then take it from there lah. It's difficult to sort of differentiate, it has to sometimes when you get all this, then baru kita tahu the progression of the disease. But I think in terms of CRS and all tu macam dah shut down because dah beyond day 14. If you look at you have to wait for the CRP, look at the absolute lymphocyte and all lah. But I think the two things top in my mind would be organizing pneumonia, and also secondary bacterial infection. Yeah, if that helps.
Okay, so would you consider this patient as a clean patient?
Oh, okay, this off-tag thing pun again, it's quite difficult to say, but generally we know that beyond day 14 of illness, they should be clean. We still follow that guide of if Cat 1, Cat 2 at day 10, we off-tag them. Category 3 to 4, generally 10 to 14 days depending. And then category 5, we tend to keep them up to 21 days. But there are conditions where category 5, kalau sustainably oxygen dia boleh improve and patient clinically better, we do off-tag them more than 14 days, tak sampai 21 days. So it's case to case as well. But for your patient here, I would actually consider clean because beyond day 14, and it's probably more of OP or bacterial pneumonia as opposed to COVID lah. Provided the day of illness too, memang you're very certain that he can actually give history that is day 16 lah. And if not, then if you have the black and white positive PCR date, then you kira from there lah kot. And tengok macam mana.
Okay, thank you so much.
Right, welcome.
Assalamualaikum, Dr. Khairil.
Waalaikumsalam, Nafisa.
Yeah, my name is Nafisa. So I would like to ask about the those with category 3 with positive ET test. So we treat as Cat 4, so we start steroids. Basically the same follows for the anticoagulant as well.
Yes.
Okay.
Generally, kalau dah start steroids too, we will throw in the DVT prophylaxis together. These things keep on changing lah, Nafisa. Dulu, I mean, the previous waves and now we've been taught that category 3 with positive axial test is not considered as Cat 4. They just consider as category 3 with warning signs, so they don't need steroids. But looking at our current patients that we have and in the wards as well, those with Cat 3 with ET positive, somehow they deteriorate fast, more so if their CRP is already high to begin with. So that's why we sort of make a conclusion that if category 3 ET positive, more so kalau CRP dia memang tinggi and the X-ray is so bad, then we just straight away treat as Cat 4, so we start steroids and also DVT prophylaxis together.
Okay, thank you. It's because we do usually the one that end up in our ED or ward, those Cat 3, those are dependent, meaning they macam orang tua yang tak boleh nak buat ET. So macam ada sakit lutut ke whatever, right? So for this type of patients, I mean, are we looking to other parameters pula to detect the early hypoxia, like how do we, because the blanket rule of Cat 3 with positive ET to start as Cat 4 doesn't actually covers all patients lah. That's my opinion.
I think in this group of patients yang tak boleh buat ET for whatever reason, is actually the next best thing is to rely on their ABG. But again, as you have a point there, because we are not exiting them when we do the ABG. I don't really have an answer for that, but generally patient macam ni dekat ward, kita just we just take off their oxygen, do a baseline ABG. Generally kalau PaO2 dia less than 80, then we will consider that there is some degree of hypoxia lah. So, again, this is not, it's not like, I mean, it's not in the guideline cover, but this is basically how they will help us to see whether this patient has got baseline hypoxia ataupun tidak lah. I know it's difficult sometimes to exit them for whatever reason, but probably that's the only way how we rely on the baseline APG.
Okay, sure. Thank you.
Welcome.
Jadi rasanya tak ada any more questions, I think. So Saya ucapkan terima kasih kepada Dr Khairil kerana sudi memberi lecture yang sangat informasi pada hari ini. Terima kasih sekali lagi daripada Jabatan Kecemasan. Dan kita akhiri kita punya CME dengan Corona. Terima kasih semua.
Okay, terima kasih.